Good evening all. Today I'll be presenting a class on
Yes, start again.
So high myopia is a leading cause of visual loss, especially in younger populations, and a major cause of legal blindness. Ethnic origin seems to influence the likelihood of developing pathological myopia. The prevalence is higher in Asian populations and lower in African and Pacific island groups. Visual acuity loss is associated with choroidal neovascularization and progressive atrophic changes in the macula, which develop usually by the fifth decade. In younger patients, a rapid visual acuity loss is more commonly associated with development of CNVM. These membranes may develop more frequently in presence of lacquer cracks or patchy atrophy. Definition of pathological myopia. It is a high myopia. It's a degenerative or malignant myopia. In the clinical practice, we may consider pathological myopia as an axial length exceeding a certain threshold, typically more than 25.5 to 26.5 millimeter, refractive error greater than 6 diopters, provided that the average refractive power of the cornea is 43.5 diopters in the absence of sclerophakia or nuclear cataract. Typical posterior pole features include tessellated fundus, lacquer cracks, diffuse or patchy atrophy, CNVM, macular atrophy, posterior cephaloma, straightened and stretched vessels, temporal peripapillary atrophic crescent, hemorrhages, and tilting of the optic disc. So pathological myopia has been classified by meta-analysis for pathological myopia study group. It is classified into 4 categories. Category 0 is no macular lesion. Category 1 is tessellated fundus. Category 2 is diffuse chorioretinal atrophy. Category 3 is patchy chorioretinal atrophy. And Category 4 is macular atrophy. Cases with fundus findings consistent with Category 2 and above are only diagnosed as having pathological myopia. 3 additional features called as plus signs include the lacquer cracks, myopic choroidal neovascularization, and the fuchs spots. So in this picture, we can see that due to generalized depigmentation, the entire fundus is appearing tessellated, that is tigroid appearance. And there's areas of generalized, that is diffuse atrophy, which do not have well-defined margins, shown by the white asterisks. And additional focal patchy areas of atrophy with well-defined margins, shown by the black arrows. Lacquer cracks, these are the characteristic findings of pathological myopia. They appear as multiple yellowish-white irregular lines, usually horizontally oriented and coursing the posterior pole. Microscopically, they consist of a healed rupture in the retinal pigment epithelium Brooks membrane choriocapillary complex. Lesion is most probably associated with the preceding subretinal hemorrhage and is often found within a posterior cephaloma. Highest incidence is found for axial lengths between 31.5 to 32.4. Male to female incidence is 2:1, and the incidence reduces with age. CNVM develops along its margins.
The, the slide is not visible. Slide is not progressing. You can stop share and share the PowerPoint again. Don't share the screen, share the PowerPoint. Yeah, okay.
Is it moving now?
Have you shared the screen or the presentation?
The PowerPoint, sir.
Okay, it's not moving. Go to the presentation mode, this thing, slideshow mode.
So now is it happening?
No.
Is it moving now?
Now it's moving. Yeah, go ahead.
So lacquer
Just
cracks they
repeat
appear
about
as
lacquer crack.
lacquer cracks appear as multiple yellowish-white irregular lines, usually horizontally oriented and coursing the posterior pole. Microscopically, it's a healed rupture in the retinal pigment epithelium Brooks membrane choriocapillary complex. This lesion is most probably associated with a preceding subretinal hemorrhage and is often found within a posterior staphyloma. Highest incidence is found for axial lengths of 31.5 to 32.4 millimeters. Male to female incidence is 2:1. The incidence reduces with age, and CNVM generally develops along the margins of the lacquer cracks. DDs of lacquer cracks should be differentiated from two similar diseases of the Brooks membrane, namely angioid streaks and choroidal ruptures. So angioid streaks usually emanate from the disc and tend to be straighter and are reddish in color, whereas choroidal ruptures are preceded by trauma and may form arc-shaped patterns at various distances out from the optic nerve at the center of the curves. However, they appear to be somewhat thicker and do not crisscross. The next lesion in pathological myopia is posterior staphyloma, also called as Karpa staphyloma. It is present as a crescentic shadow located 2 to 3 disc diameters from the optic nerve. There will be alterations in the retinal vessels in the identified area, and on indirect ophthalmoscopy with 20D lens, the affected area appears to be depressed from the adjacent retina. B-scan will show an increase in axial length with excavation at the posterior pole with corresponding choroidal thinning. OCT scan shows a macular gradient. This triangle represents the macular gradient. Scan taken in this OCT is a transverse scan. Between the macula and the optic disc area, there is a steep macular gradient which is observed, and the staphyloma protrudes towards the temporal retina. So, progression. So, which lesions are more prone to progression in myopic pathological myopia? Hayashi et al. Proposed a longitudinal progression pattern of myopic maculopathy from a tessellated fundus, which is the initial stage, to macular atrophy, which is the last stage. During the mean follow-up of 12.7 years, percentage of eyes showing a progression to myopic maculopathy were as follows. Eyes with tessellated fundus had the least progression rate, whereas eyes with the lacquer cracks, with patchy atrophy and with CNVM had the greatest progression rates to myopic macular atrophy. Genetic associations, common genetic disorders associated with high myopia, Stickler syndrome, type 1 and type 2, type 4 Ehlers-Danlos syndrome, Knobloch syndrome, and Marfan syndrome. According to Wojciechowski et al., many of these genes are involved in common biological pathways known to mediate the extracellular matrix composition and regulate connective tissue remodeling, mitochondrial mediated cell death, or photoreceptor mediated visual signal transmission. Parental refractive status plays an important role in refractive status of their offspring. Now, the CNVM in pathological myopia. Neovascularization was histopathologically observed in 5.2% of the eyes with pathological myopia with an axial length longer than 26.5 millimeters. Development of CNVM in both eyes may be simultaneous, but this is not the rule. Ono Matsui et al. Described an incidence of CNV 34.8% in the fellow eye of patients with pre-existing CNV in the other eye, but only 6.1% in eyes with no previous CNV. Myopic CNV may account for as much as 62% of CNV occurring in patients younger than 50 years of age. Highly myopic eyes with lacquer cracks or patchy atrophy close to the fovea have a higher risk of developing CNV, and Fuchs spots represent a late stage of myopic CNV. Histopathologically, shown them to be consist of an ingrowth of fibrovascular tissue. Risk factors for CNV are highly myopic eyes with lacquer cracks or patchy atrophy, older age, eyes with reduced choroidal thickness on SDOCT, eyes with choroidal filling delay on ICGA, and female gender because estrogen receptor expression in CNV and external estrogen influence. Hayashi et al. Studied prospective 57 eyes with myopic CNVM during a minimum follow-up period of 5 years. Patients with final visual acuity greater than 20/40 but significantly younger had significantly smaller CNV, significantly better initial visual acuity, and juxtafoveal CNV was more frequently observed in this group. And younger patients might be able to retain good vision for a while. However, after a long period, most patients with myopic CNVM usually have a poor visual prognosis, regardless of the age of onset. So, pathogenic mechanisms. Ikuno et al. Hypothesized that axial length elongation alone does not cause a myopic CNVM, and there are many other latent factors. It is found that myopic CNVM, the subfoveal and inferior choroid is slightly significantly thinner than the average fellow eyes. One possible explanation is that choroidal vessels supply the retinal oxygen to the outer retina. Outer retina is believed to be a major source of vascular endothelial growth factor, and the choroidal thinning at the fovea may lead to outer retinal hypoxic changes via factors such as hypoxia-inducible factor, resulting in VEGF secretion at the fovea. Myopic CNVM progresses through three main stages. In the initial stage, there is a direct damage to the photoreceptors, causing central visual loss. Then, as the CNVM regresses, a fibrous pigment scar forms, referred to as Foster-Fuchs spots. And finally, chorioretinal atrophy develops around the regressed CNVM, which results in poor long-term visual acuity. Clinical findings on biomicroscopy, the CNVM typically appears as a less than 1 disc diameter area or less than 1000 microns area in diameter, flat grayish subretinal membrane with hyperpigmented borders. They are located. Important to notice that they are located in the subretinal space. So it's a type 2 CNVM as opposed to the sub-RP space in age-related macular degeneration. And subretinal or sub-RP fluid and hemorrhage or exudates are uncommon. Location of CNV is most commonly reported to be subfoveal, and it can also be juxtafoveal or extrafoveal. Extrafoveal CNVM is also known as periconus CNVM, which is located around the myopic conus. On angiography, FFA is still the main tool for diagnosing myopic CNVM and has been used in all randomized clinical trials for evaluating the need for therapy in CNVM. Almost 90% of the myopic CNVM will demonstrate mild hyperfluorescence confined to the early phase of the fluorescent angiogram. Most membranes will hyperfluoresce in the arteriovenous transit phase, but contrasting with the AMD, only a minimal leakage will be found beyond the borders of the lesion in the late phases. Avila et al. Have found that less than 10% of myopic CNVM leak beyond the borders in late phases, and if the leak is less, then this finding is found to be associated with the worst prognosis. On ICGA, visualization of myopic CNVM can be complicated by several factors, including reduced leakage, presence of staining associated with lacquer cracks, and subretinal hemorrhages. Even with these limitations, FA is able to detect myopic CNVM in most cases. However, when large hemorrhages are present, ICG angiography may be better able to identify the CNVM as a faint hyperfluorescent spot or area, often surrounded by a hypopigmented halo. ICG also allows for better definition of the lacquer cracks than FFA, and ICG allows a more precise CMV localization and filter vessel detection. So here in indocyanine green angiography in the early phase, pointed by the white arrow, we can see a faint hyperfluorescent spot with a hypopigmented halo, and in the late phase, we can see a lacquer crack. OCT using enhanced depth imaging modality, choroidal thickness was studied in normal eyes and was shown to be thickest underneath the fovea and has an inverse proportional with the age. Myopic CNVM on enhanced depth imaging SDOCT has following characteristics. It's a type 2 neovascular membrane associated with a very thin choroid. Choroidal thinning is more prominent in eyes with myopic CNVM when compared with eyes without myopic CNVM. And chorioretinal atrophy adjacent to the myopic CNVM increases the risk of developing a macular hole. So, and OCT also helps in diagnosing other associated features like PVD, posterior staphylomas, retinoschisis, macular atrophy, hemorrhage, retinal traction, or macular hole formation. So here, OCT shows a spindle-shaped hyperreflective area above the retinal pigment epithelium, suggestive of choroidal neovascular membrane, and there is absence of associated subretinal and intraretinal fluid and associated choroidal thinning. And on octa, we can see abnormal branching network of vessels located at the level of deep capillary plexus. SDOCT is also recommended for evaluation of the posterior staphyloma. Aikino et al. Reported that absolute value of the nasal posterior staphyloma height from the fovea is significantly greater in eyes with myopic CNVM than in myopic eyes without CNVM. But OCT also has drawbacks. OCT alone has poor sensitivity in diagnosing recurrence due to choroidal thinning present with pathological myopia, associated pathological myopia. In such cases, the extent of perfusion of CNVM on the pathological myopia should be evaluated using fluorescein angiography. A treatment point to be noted that suspicion of CNVM formation should be high in cases of myopia with a history of recent onset of metamorphopsia. The number and frequency of intravitreal injections required for myopic CNVM are generally less than those required for CNVM associated with age-related macular degeneration. However, these patients do need to be kept under regular monthly follow-up and need to be retreated in case of activity. So treatment, anti-VEGF agents are the first line. The regimen is generally pro-Renata, that is as and when needed throughout, or it can be loading dose for 3 months followed by PRN. Myopic patients are younger with a healthier RPE and hence lesser frequency of anti-VEGF injections may be effective. There were 3 studies based on the anti-VEGF agents. One was REPAIR, the Radiance, and MIRROR. The REPAIR study was a 12-month study in eyes with active sub or juxtafoveal myopic CNVM treated with 1 injection followed by Prodenata of intravitreal ranibizumab 0.5 milligram, and it showed that ranibizumab improved the visual acuity on average in 12 months with low rates of serious ocular adverse events. Then the Radiance study showed efficacy and safety of ranibizumab. Prorenata dosing of ranibizumab was found to be superior to PDT in the Radiance study, and Mirror study for aflibercept in myopic CNVM in Asian populations has found it to be safe and effective. Then other treatment modalities which are lesser used or obsolete are thermal laser photocoagulation. They are not preferred. Laser photocoagulation itself may be associated with formation of lacquer cracks and increased incidence of recurrences at the foveal edge of the scar. In photodynamic therapy, initial benefits of photodynamic therapy for myopic CNVM were supported in the VIP study, but initial stability of visual acuity was seen in the initial period and worsening was seen with time. Then transpupillary thermotherapy, low energy, longer exposure, 810 nanometer diopter laser gently heats up the CNV, leading to closure of the abnormal neovascular vasculature, apparently sparing the overlying neurosensory retina, but it is no longer used. And lastly, controversial surgery, removal with submacular surgery, like limited macular translocation or macular translocation 360 is done, but it's controversial. These are my references.
Yeah, so as compared to the age related, like for example, a aged myopic patient, how do you differentiate it from age related macular degeneration?
Sir, OCT characteristics in classic this thing age-related macular degeneration, it can be occult or it can be type 2, but in myopic it is generally type 2, and choroidal thinning is more commonly associated with myopic CNVMs. Absence of drusen as well.
Yeah, so first thing will be absence of classic other like drusen and pigmentary changes. So myopic CNVM usually they present with metamorphopsia. That is the first symptom. And sometimes on OCT you may have very little changes seen, but if you wait, it develops fully. So I think we have to give more importance to symptoms, particularly myopes who are one-eyed. Like one eye is already having low vision, and this side develops metamorphopsia. Look closely for the CNVM. And what treatment regimen is generally advised for myopic CNVM?
So PRN is generally advised.
Can
One
you?
initial injection, and then you monitor on the OCT, and if the CNVM regresses, then you inject as per the size of the CNVM.
Yeah. Okay. Fine. Any other doubts about this? Any other? Any Other students or fellows, any doubts? So what are the usual findings in pathological myopia on OCT? Not CNVM, other findings.
There'll be posterior staphyloma will be seen, sir. Choroidal thinning will be there.
Hmm. So
And
choroidal is very common in high myopes. Okay.
then
Posterior staphyloma, you said, and other pathological changes which are posterior fugue spots. So these,
posterior.
yeah, is of atrophy and hemorrhages. Sometimes these hemorrhages are mistaken for CNVM also. So in such cases, maybe OCT angiography can help to differentiate, or angiography. And another important this thing which happens is tractional maculopathy or
Macular.
fovea. So what are the indications for treatment in case of myopic maculocytosis?
Metamorphopsia, decreased vision.
Yeah, we have to do ERM, ILM peeling and put gas. But most of these patients have posterior staphyloma associated, making the surgery little difficult. Okay, for myopia, any treatment to prevent myopia from developing?
Sir, Atpine PF drops we give like to halt the decrease the progression. 0.01% atropine.
Okay. And how long do you have to continue these drops and what is the age criteria?
So as far as I have seen, they are continued for a year or two. Like.
Anyone else wants to answer? Yes, Dhanraj.
Sir,
Can't hear. Can you repeat? Hello. Can't hear. Okay, can't hear. Amo, can you repeat?
Sir, he said that till 18 years of age we can prescribe the drops, and at the time they can be given for 6 months. Yes.
Yeah, not 6 months. You can continue for 2 years and even longer. The initial study was for 2 years, and 6 to 16 is the age group where we can give it. And of course, because it has very low side effect profile, it is extended to longer period of treatment also. Any other concentration of drugs which can be used? Any other concentration of atropine?
And only once. 0.01.
Yeah, that is one. Any other studies going on any other percentages?
Don't know, sir.
Okay, you have to read about it.
Yes.
The common dose used, is it OD, BD?
It's HS, one OD.
Okay. Okay, fine. Any other doubts?
Sir, management of posterior fugue spots, if you could.
Observation. There is no treatment required for posterior fugue spots, but many times we mistake it for CNVM, so get treated with anti-VEGF, but usually they just they are self-resolving. the hemorrhagic spots, not the atrophic part.
Sir, it is said that the hemorrhage occurs less frequently in myopic CNVMs as compared to the age-related macular degeneration. So, how do you clinically assess if the lesion is active, if there is no hemorrhage? Hemorrhage is less.
OCT.
Okay.
And also, if there is significant subretinal hemorrhage in myopia, then you should also suspect IPCV, because myopic CNVM, as you said, rarely bleeds so much.
Yes.
So subretinal bleed is more characteristic of IPCV than myopic, or even not so common with ARM. ARMD is still there, age-related CNVM, subretinal bleed is there, but massive bleed is seen more common with IPCV. Okay. Okay, if there are no doubts, then we can conclude the meeting. Okay.
Yeah.
Thank you.